to the stage, I should say, for our discussion panel. I'm sure there'll be many questions and comments and thoughts. So all the speakers, please come up. I know I went a bit over time, but we will catch up time so you can also get to the posters. I will ask Ruth to help me chair this. We'll share our voices. So we'll have this session through till 3 p.m. and then we'll move to the poster session. So take a seat. Super. How this is going to work is it's fairly informal. So if you have a question, we have roving mics. Please just put up your hand or stand up. Let us know who on the panel you'd like to ask it to. And if there are multiple people, please let us know. Who wants to start?
Yeah, at the very back.
Thank you. Reed Kaplan here again. This is a question for Dr. Phillip. Correct me if I'm wrong, but I think earlier in your presentation, you intimated that the treatment that you were trying for PTSD with TMS was to the ventromedial prefrontal cortex and the amygdala, and I assume it's a connection via the uncinate vesicular regions. Is that correct?
So there we go. So the TMS that I was showing everybody in all of those slides, the transcranial magnetic stimulation actually was standard, boring dorsolateral prefrontal cortex.
Okay.
So the biology, right, always involves the ventromedial prefrontal cortex and its various connections. But it is remarkable that treating the DLPSC seemed to work quite well for post-traumatic stress as well.
Okay, and follow up to that, regardless of the actual connectivity, did you examine whether it made a difference if you stimulated the dominant versus the non-dominant hemisphere?
So I love the question. So I can't take credit for answering that, but I'll direct to some work that's been done by my colleague, Andy Kozel, who's actually done a lot of work stimulating ipsilateral and sort of bilateral sides. Mm-hmm. I think that the simple answer is that the motor dominance doesn't link well with the psychiatric symptom change. But I think there's probably a lot more in there depending on how folks may be wired. Even so, most affective symptomatology seems to manifest predominantly in the left frontal lobe, which would be dominant in most people, correct? So yeah, and I think, and we also have to remember, and sort of the broader comment here is that folks have largely stimulated on the left dorsolateral prefrontal cortex because that's where the field started, and they found a signal, and so folks have done what they know works. And I think there is not nearly as much looking at different spots.
Thank you. Thanks.
Yeah.
Oh, Walter, go ahead.
What I have. Leanne, I remember you had incorporated into the ENGAGE study some behavioral measurements using Mindstrong's approach and others. I haven't seen that talked about very much in today's presentations, how we can, using ecological momentary assessments and other ways of capturing behavior. And I'm just wondering, is that something that is the next layer on top of this to be done soon? Or is it an aspect of we don't have very accurate measurements in that arena, so we're dialing back? Just curious about the thoughts of the panel for incorporating more behavioral measurements.
It's a great question. I might ask Helen to jump in on this one. Yeah.
I think the concept is right. I think the level of complexity needed is being worked on. So I think, it goes way back to even Kreplin thinking about movement in bipolar and how regular, irregular movement can emerge and that those properties aren't linear and how you can pick them up. So I think embedded in movement on a watch with actigraphy or foraging and even novelty. There have been some interesting papers that I'm going to miscite that have tried to look at reward processing and foraging as an indicator that you can do a readout on mood by the amount that you move when you walk around in your environment in a novel way. So I think but it's not a straightforward metric, as people have shown even in cardiovascular disease. On the other hand, this thing of asking people how they're doing all the time is really annoying. And I don't know if anybody has actually done that and tried to do it before you have someone else do it. You basically throw the device at a wall after a couple of days. And I think it is sort of remarkable that people will do those things, but I think as soon as you ask someone the question, you don't get the answer you really want. So the notion, though, of what people's personal experience is and how you capture it is actually really important. So I think the emerging natural language processing models that just even in the last year have just blown up, that going from it costs you a fortune to transcribe an interview to you can throw it into Whisper and get a perfect transcription in any language pretty fast, allows you to build models on the nature of what people say and how they say it, which is the fundamentals of behavior. And I think that naturalistic data capture in dense ways is going to evolve. But I think it's the thing that Leanne said so brilliantly, and that was really inspiring to hear about your place, by the way. But this idea that if the brain leads, how do you simplify and how do these things tie together? But what's the right data and the right density of collection to build the model that you want that goes with the brain state? Because they're not collected. When you do intracranial recordings, you get slammed all the time about time syncing. And how can a time sync for a behavior match the brain state? I don't actually believe you actually need that, because these signals are actually kind of slow. And so I think that the wearables in all of its forms, by how you talk in your texts and how we deal with the privacy, is another issue, but the signal is there and we just haven't modeled it quite right.
This is a serendipitous question, but how about a psychiatric evaluation as a requirement for a prerequisite for running for political office? Perhaps that would save the world a lot.
As an employee of the U.S. federal government, I am definitely not going to touch that question.
So maybe I could ask a question that is not on my list, but I was very intrigued, Dr. Tozzi, with a slide that Dr. Williams showed that talked about 5,200 cognitive tests. And I wonder, could you expand on exactly what kinds of tests those were and where they were sourced from? That was kind of impressive.
Yes, so, sorry. Yeah, sorry, mine is, oh, no, now it works. Sorry, it just took a second, sorry. Yes, so this is really one huge advantage at the center. So for many, many years, Dr. Williams and others have been collecting a very large amount of behavioral data. And the huge advantage, like in the studies we showed before, and also what Dr. Williams was saying, is that the same standardized cognitive battery has been used across all studies. So not only we have this data from a very large amount of people, and this involves, for example, measures of memory, reaction times, emotion processing, executive function, various forms of cognitive measures, but also healthy norms to which we can then norm this data. And so express really at the level of the individual how affected each cognitive domain is. So that's the huge advantage of being consistent in data acquisition, and then that enables us to pool this data across a very large number of people. And we think going forward that's going to be a big asset as we focus more and more also on the cognitive aspects of the disorders we investigate, for example, depression. And that's going to be a gold mine for that.
Well, that's very helpful to hear and very exciting. There is not a standardized approach to assessing cognition in younger adults with a range of psychiatric disorders. We have a very strong body of empirical data in depression, for example, as people get older. But these ways, more digital ways of assessing cognition in real time, I think could be instrumental. So it's very exciting work that you're doing. Yeah. Dr. Kuhn.
Hello, it's good to see Ruth and good to see you, Leanne. I'm wondering about, in the Bay Area, even beyond the Bay Area, it takes a very, 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 very long time for somebody to get into treatment, to begin with mental health treatment. So I'm wondering how you kind of balance accessibility. We have slides filled with all of these measures and all this stuff we're going to do, and then we're going to find it, and then we're going to do this. But in reality, I heard a statistic that it could take up to a year up at UCSF for somebody with depression to get into the clinic. Down here, it's not much better. So maybe just a little bit about like precision medicine, precision mental health, and accessibility, and especially like in a privileged place like this, and there's the rest of the world.
I guess I could start. Do you want to jump in, Carolyn? Yeah. Thank you.
Yes.
Testing. Okay. Dr. Kuhn, thank you so much for this wonderful question. And, I think, for me personally, I think that my research is just but one domain of what's important and necessary for mental health. And at least in OCD, it takes 14 to 17 years for somebody to be identified. So part of, I feel like a mission is advocacy and outreach and help. And Stanford has a wonderful resource of videos that are for the community, for education, that are free videos available on YouTube. And they're doing them in English in different disorders and also in Spanish translation to increase accessibility and access. And I'd love to take your question back to you, which is you're doing really brilliant work in digital therapeutics, both at the VA and beyond, and just have done such an amazing training for students. And I really feel like that is the future in terms of increasing accessibility. So I hope you don't mind. I would love to hear a little bit more about, what you've heard and what you think could be ways to open this as well.
Sure. Well, of course, I would advocate for more digital therapeutics. I think the assessment side of it and what we can do with wearables and passive sensing is really the new frontier, where we can just get these data without having to burden people with bothering them 6 times a day with a prompt. And throwing with our veterans especially, throwing things at the wall would probably be that morning of the first time they get binged. But I do think that having these scalable, I don't know if we want to call them low intensity, maybe high reach. I think Keith Humphreys calls them high reach interventions, but also just kind of balancing that with, we're going to be putting these out there, and are we going to feel like, okay, well, we've covered the low and middle income countries with these things, and over here we still have all this great stuff that's going on, and therefore we don't have to worry too much about that. That's my burden, is that my concern is that we're going to leave a lot of folks behind because we're going to feel like we're doing the right thing for them when maybe they're not getting exactly or the type of treatment that they would need.
To that point, Eric, and we're way ahead of the field in trying to get some of these applications, both for tracking symptoms as well as for treating. In 2013, I was 2009 to 2013, I served on the DSM-5. And we were asked in the first sort of sessions, as they were teeing us up for our work groups, on what would you wish for the DSM-5 to do that hasn't been done? And I raised my hand and said, I think greater integration with physiological systems. Leanne talked about cortisol, but we also have glucose monitoring, which I think is going to revolutionize our understanding of the relationship between blood sugar levels and psychiatric symptoms. Obviously not the case in all cases, But really, there's an unprecedented opportunity here to integrate. At that time, when I said better assessment of physiological systems beyond the mental health systems, I was told that was a pipe dream and pipe down. And now I have to say that this is a vision that also can be operationalized. There's so many systems for sleep, for glucose metabolism, for stress, that we can measure in real time with the kinds of applications you've developed to actually get and see if there are interactions there that are maybe very potent. Type 1 diabetes has one of the highest rates of suicidality, for example, and yet who's tracking that in real time, particularly in rural and more distal populations that may not have access to the care you raise. So I think it's a wonderful opportunity at this point in time.
Maybe to mention, pausing, to mention, picking up on that theme of integration. And I can circle back to the elephant under the carpet about cost as well, which I'm always asked about, understandably. To me, that what Ruth was just highlighting about physiological measures being routine for diabetes or other conditions, that's an opportunity to harness what has been done for mental health, because obviously it would be a huge shift to have mental health integrated as part of health fully. But if it was, we'd be able to make use of all of the workflows and systems that are already available for all other conditions, including the imaging facilities, the EEGs, and we'd have the evidence base for linking those to the wearables and the, what did you call it again? The high, not high touch, but the high reach measures, which I again go back to Framingham, that I think did a great job of that, because they've linked the understanding of the organ of interest to those high reach measures. And I've been very heartened by conversations and collaborations with other disciplines. So I'm including radiology, neuroradiology, I'm including all the disciplines that use EEG, and then those who are at the front lines clinically. Neuroradiology has been fascinating. I've spoken at their meetings and I learned to my surprise that they're thinking that psychiatry is already has the solutions and that we're waiting on them. So from neuroradiology's point of view, at least from my experience, they're saying we're ready, like we're used to introducing new assessments for whatever is the next and complex condition. We've done that for all of the conditions. So yes, scale is an issue, but that's what they do. And then that idea of how do you link to the high reach. Of course, there's the cost and access issue, and I've really looked a lot at that because the costs are very different as to whether you're talking about research or clinical use and which country you're in. Research-wise, we think of imaging as expensive because it is upfront expensive. In terms of the actual allocated cost in the clinic, is not that much different, excluding facilities fees, between imaging and EEG used in sleep and other areas, the actual cost of the assessment. It's about then 1/3 of the price in many other countries, and it's routine. If you need to have an evaluation for migraine, you would be referred for a scan. So I think if we had the opportunity to have these tests available, the cost and would come down and the workflows would be there to make it efficient. And of course, not everyone will get them, but that's been addressed in areas like mammography, where it's like, if you don't have access to the scanning facility, how can we get to you? And how can we get to you with maybe an outreach measure that gives us a good proxy, even if it may be taking a photograph. So I know that was a free association, but I'm sure Helen wants to jump in. Yes.
So not to be a buzzkill, but there is, I think, the issue of how resource allocation will happen, given that we have the most you can do but then to actually scale it to the people who have the least, and to how to get all the data we need to know what part is necessary and sufficient, and then to have resource allocation that can move through the pipeline so that everybody has access to the basics, but that basics assumes that there is a basic, which implies that the biology has an evolution over time, that it isn't just equally potential match people to the treatment that they need because everybody has a treatment and you just kind of move through the system until you get matched up. But in fact, how do we create awareness, if it's true, that actually getting the wrong treatment isn't just wasting time, but is actually hurting you? And I think that, you know, in the evolution of stroke, I mean, I remember when I was a resident, somebody would show up hemiplegic and couldn't speak, and the family would be there and you go, how long has this been? And it'd be like 3 days. And when was it going to occur to you that not being able to move the entire side of your body or speak was like actually bad? And it became the education of what is a stroke. And then as the treatment became, there's a window to treat, then things mobilized to do things in the same way. How did we teach people that chest pain needed to be dealt with, but how do you parse the difference between a heart attack and a bad burrito, and that they might feel the same, but not. But I think that the thing that we didn't really talk about today was the idea about, you know, and again, England went through a period, remember, it was about 20 years ago, that no, drugs are, you know, everybody got drugs as a first line, and then nobody got therapy. And then they did 180 and said, oh, everybody should get therapy and we should teach everybody how to do CBT. Then nobody got drug. And we're back to the thing as though it's one is better than the other, rather than you need to be getting what you need. And then it gets into, are there stages of these illnesses where actually the timing matters? Because if timing matters, maybe if you identified someone with symptoms that the stress was creating a pro-inflammatory or pro-insulin sensitivity state, that actually the glucose would tell you that you had the problem, or vice versa. And how do we build these platforms so that we catch the kind of the diaspora faster with the least expenditure? Because I mean, what I did at 1 o'clock was I had to be on a call for the National Academy of Science on DBS. And why hasn't DBS, not for what I do, but even in Parkinson's, you talk to people, you have readouts, you have these devices built, nobody has time and nobody's learned how to do it, and the education is bad. So you build the device, you build the stuff, you have experts that know how to do imaging or physiology, you have no way to translate it so that regular docs can do it. So I think the thing is, how do we take what you do, which I certainly want to know more about, and actually how do we triangulate so that things that are done in many things meet the things that are done in a few? Because you'll never get neuroradiology to be able to do what we heard today about these analytics, because there just won't be personnel when you're reading 500 scans a day to invest that time unless you can build the algorithm. So how do we bypass it so that the most people get basics, and then you move up the pyramid so that very few people need what I do, or that I kind of reverse engineer to find the people earlier on, not use resources and get them back to functionality.
Yeah, so it definitely sounds like that efficiency that could potentially come out of this would open up resources for a whole group of other people that wouldn't have those resources available. So thank you.
And sometimes, to Helen's point, that that point of the scaling is not actually where you might think it would reside. So a very good example, we have an investigator, Terry Klein, who resides in our Department of Bioinformatics and Data Sciences. And she got a center several years ago to actually collate and curate all the data, and you can imagine how much it is, on pharmacogenetics and treatment response. And eventually, out of all the thousands and hundreds of thousands of data points, we're now at a point where there are several fairly standard medications that have profound negative adverse effects in certain individuals. And they actually created really a list of that. And so the question became exactly as you asked, how do we get this out to the community, to the clinician? What is the clinician going to do? Order a genetic test or a boutique test? And what they actually did, and it started, they went to some of the hospitals, and not to the clinicians, but to the pharmacists. So the hospitals, and one of them in Cincinnati, has actually taken that information, just a very small set of genetic markers that have profound adverse effects with certain medication interactions that save thousands in terms of the time in hospital, the mortality rates. And of course, what's happening now in this educational piece is that they're telling others how to do this because the cost savings for the hospital is so dramatic. And I think what we have to do, to Leanne's point, is look at some of these other models and see where we could take a model like that. Are there some aspects of what we bring to the table in our tools that could benefit, pharmacogenetics being one of them, and help with an increased precision medicine approach applied to mental health? But there are examples of other scaling, just not yet in our domain.
I feel like this discussion could continue. Maybe we could continue it over the poster session. You were very generous in keeping on time, everyone, today, and I am not on time right now, so I don't want to hold you back from the poster session.
One last question of Dr.
That's
Zhang.
exactly what I was going to suggest. So we're going to wrap up with one question, and then we'll head to the poster session. So this is one for you, Dr. Zhang. Given your results are from healthy people, how would you like for them to be used for people with psychiatric disorders?
That's a great question. So I want to answer it in two ways, but keep it short because I know people are excited about the poster session. Despite our findings from a healthy participants group, actually, they show certain level of PTSD symptoms, and some of them even reach the level of moderate PTSD symptoms, and they also suffer from early life stress. So from that point of view, we believe our findings could be translated into the clinical population. The second point is we're actually in the plan of trying to collect subjects with more clinical symptoms in the phase 2 data collection of our sample. So please stay tuned. We will have more results maybe next year for the next symposium.
Thank you to all of our speakers. I'm absolutely honored that you all joined us today and presented. It was a brilliant program. I'm sure you'll all agree. Thank you. And thank you to all of us, all of you and all of us for coming together. I really appreciate your participation and your engagement. Please enjoy the poster session and the extended happy hour. There are drinks and snacks and more great science, and it's just next door. So thank you again, and thank you to our speakers. Please join me in thanking them.